Dear ladies and gentlemen, evaluated the effectiveness long-term results up to 4 years use a new method, a mechanical separation of posterior hyaloid from fovea in stage 1 macular hole without stain agent and without vitrectomy. In randomized comparative study included 130 patients with a first stage macular hole with average visual acuity before surgery 0.93. The representativeness of study sample of patients defined by specificity. The presence of macular hole truth on the other eye. First step, 27-gauge mechanical separation of posterior hyaloid with xenolite and stage 1 macular hole without vitrectomy was developed by me in 29 years and made message on your retina nice. Results of the first operation. Next step, 27-gauge separation posterior hyaloid with a green light source and low light, only 2% from source power, 100 patients. And results. After 2 weeks, next day after operations, complete separated, and stage 1B by gas macular hole. You see results after next day. Third step, currently running mechanical separation under the control of intraoperative OCT, 20 patients. And first step, capture posterior hyaloid. Second step, elevated nasal quadrat and complete separation. Complete separation you may see on videos in real time. One step, I have a little time because any second and I end of presentation. All of 130 patient posterior hyaloid was separated. Macular hole truth formation was observed. Only 2 of patients, 1.5% of cases. You have no microscope with OCT when a problem with the surgery will be a visualization of transparent membrane. I use the necessary 7 principles of visualization, the transparent structure. Together with Dirk Corporation, we create a special tools for this operation. And conclusion, average this technology as an actual point in application in operative OCT, or in 100 cases control delicate results detachment of membrane is guaranteed. In interrupt the pathological process, eliminates the cases of diseases, single intervention, reduce risk of complication of vitrectomy. It is alternative existing method, staining with vitrectomy, CF6 intravitreal injection, and chemical lysis. Thank you for your attention.
Any comments?
Yaroslav, I just want to ask you one thing. Since you are in the eye, you don't perform vitrectomy. I would ask why, because it may cause some floaters and the other problems. You can cause some iatrogenic peripheral retinal breaks while you are going in and out. And what I do in such cases is I prefer to do pneumatic vitreolysis by giving just SF6 gas and doing bird feeding movement of the head, and it's much more less invasive than the although without non-vitrectomized vitrectomy, and it has a real high rate of separation of the vitreomacular traction. So why do you think we should prefer to do non-vitrectomized vitrectomy for this case?
If you have a complication after posterior hyaloid elevation, you will see macular hole truth. You made the simple vitrectomy during into the first operation. It's no problem.
I think that what makes sense in this talk is that you have a confirmation intraoperatively of what you're doing. That's the difference. It's not just releasing the traction, it's having confirmation of what you're doing with intraoperative OCT. So in the two cases where you ended up with the macular hole, then you moved on with peeling and did the whole process?
Yes.
So you decide immediately what to do?
Yes, intraoperative OCT is not so necessary for this operation because I made 100 patients without OCT control. OCT control more better control than results.
Thank
only.
you.